All right. All right, welcome everyone. We're having everyone join the meeting. One's just coming in. And so I just want to welcome everyone to the AIHM Friday Wellness webinar. We're just really excited today to have with us our guest speaker, James Whedon, who will be talking on manipulation therapy versus opioids for older adults with spinal pain. So as everyone continues to join the meeting, I'm just going to say a couple words to get us started. So for those of you who are joining us for the first time, the Academy of Integrative Health and Medicine is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And we started in 1978 and with our sister organization AHMA and ABIHM, and really began in 2014 as the newly formed Academy of Integrative Health and Medicine. So today we have with us James Whedon, who is a chiropractic doctor. He is the Director of Health Services Research at Southern California University of Health Sciences. He is a charter member of the Academy and adjunct instructor at the Dartmouth Institute for Health Policy and Clinical Practice. He's authored 42 peer-reviewed publications and is a recipient of the Jerome F. McAndrews DC Memorial Research Fund Award from NCMIC Foundation, as well as many other things. Jim is a leader in the field and a really incredible mentor for future researchers, and we just are thrilled to have him today. So Jim, welcome, and I'll let you share your screen.
Great, thank you so much, Tabby. So, let's see. I see a lot of things here. Some of this must be yours, Tabby. I think this is the one I want to share. Yeah, this looks.
There we go.
Right.
That's perfect.
And okay, good. Okay, thanks so much, Tabby, and welcome everybody. Thanks so much for joining. So I want to give you an idea where I'm taking you today. We want to talk. I want to talk first about the value of spinal manipulation versus opioids for older adults with low back pain. I'll be reviewing a number of research projects that me and my team have recently completed. Next, then part two, we're going to look at the association between the use of chiropractic and use of prescription opioids. And just a little hint that the association is one of a negative correlation. So if you use chiropractic, you're less likely to use opioids. Probably no big surprise there. But we and a number of other researchers have quantified that. So we have a lot of information about that now. And finally, health policy for chiropractic under Medicare. So we'll be talking a little bit about the implications of recent research for policy. Okay, so first off, talking about the value of spinal manipulation versus opioids for older adults with low back pain. So how do we measure value? We know that value equals outcomes over costs. That's kind of the general idea, but specifically there are a lot of different ways we can measure outcomes, right? And one of the ways we can measure outcomes is thinking about the 6 domains of healthcare quality as defined by the Institute of Medicine about 20 years ago, now the National Academies. So they defined 6 domains of healthcare quality, and kind of within those domains, we can think about measuring outcomes, right? We can measure outcomes in terms of effectiveness, going from the top of the wheel here, in terms of effectiveness. So does the treatment work? Is the patient centered? So does it take into account patients' beliefs and attitudes and their wants and needs. Is the care timely? Is the care safe, or is it associated with adverse effects? Is it efficient? Does it do, is there associated with that approach, do we use our healthcare resources appropriately, or is there overutilization? Is the care equitable, right? So do patients get the kind of care that we need, that they need, very important, particularly for underserved populations. So we're going to look kind of selectively at some of these. We're going to be looking at safety and efficiency and patient-centeredness. And also, we don't want to forget the denominator of the value equation, costs. So, and much of the research results that I'm about to report are from this study, spinal manipulation services versus prescription drug therapy for long-term care of aged is a fancy word for older, Medicare beneficiaries with chronic low back pain. Right. So the objectives of this study were to compare spinal manipulation therapy and opioid analgesic therapy, or abbreviated those as SMIT and OAT, for long-term care of chronic low back pain. And that's important that it's long-term care. It's not just chronic low back pain, but it's long-term treatment, so for at least a year, right? A lot of the evidence that we have from clinical trials, et cetera, might just go for a few weeks. But the evidence from this study is for at least a year, and in many cases, more than a year. And so we want to compare these two approaches with regard to, one, the risk of adverse drug events, that's the safety. Two, risk of escalation of care for low back pain. So what is escalation of care? Well, normally for low back pain, conservative care will do the trick. So you get acupuncture, you get chiropractic, massage therapy, conservative non-pharmacological care, exercise at home. And it usually, does a good job with low back pain, but in too many cases, the care is escalated, right? So that goes to the efficiency of care. Number three, we looked at patient satisfaction with these two approaches. And finally, costs. So this study was a retrospective observational study of Medicare claims data. So these are huge databases, nationally representative databases, and we looked over a 5-year period. So it's an observational study. The subjects were Medicare beneficiaries aged 65 to 84. They were all continuously enrolled under Medicare Parts A, that's hospitalization. Part B, that's outpatient, office visits typically. And Part D, that's the pharmacy benefit under Medicare. And it was over a 60-month period. We measured the outcomes. Everybody had an episode of chronic low back pain in 2013. We excluded patients who had cancer or in hospice care because that could confound the reason for using opioids. And all the patients received long-term care for their chronic low back pain. And we assembled all these different cohorts, kind of created them out of the claims data. But what I'm going to focus on for a couple of reasons is these cohorts where patients either initiated their care with spinal manipulation or they initiated their care with opioids. And these are the cohorts that we ran our regression analyses on and got our results on risk, et cetera. And the reason we did that is that there's a body of literature which shows that if you start chiropractic care first or start it early, you get better outcomes, right? So we wanted to kind of be congruent with that and follow up on that and see how that works out for Medicare beneficiaries. Okay, so first up on this, the results from this study, the results related to safety. So the objective of this particular part of the study was to compare opioids versus spinal manipulation with regard to risk of adverse drug events, ADEs. We abbreviate a lot in these studies. So the adverse drug events in an outpatient setting, right, among older adults with chronic low back pain. And we used the regression analysis to estimate the adjusted incidence rate ratio and compare across the cohorts for patients who chose opioids first as compared to spinal manipulation. So here are the results. There's a lot in this table, and you'll see that there are a lot of dots, right? It looks like missing data. And in some cases, that's missing data. There wasn't any data. In most cases, actually, the data is suppressed because there wasn't very much. And if you have very low numbers in any one cell, Medicare says you have to suppress the data and not report it. And that's a way of protecting patient confidentiality. So, but there are a number of categories here of adverse drug events where we did have significant numbers. And again, as I mentioned, we're going to look at the combined cohorts. These are the cohorts where patients either started with opioids or they started with spinal manipulation. And you can see that you look at the percentage figures there, 17.8 versus 3%, right? Those are the percentage of these cohorts that had any adverse drug event. And you can see it's about 6 times higher in the opioid group. Again, about 6 times higher for opioid poisoning and also for opioid dependence or abuse, about 13.9% versus 2%. Now, you might be thinking, well, that's not such a big surprise, right? So you would expect to find this relationship that the opioids group is going to have more adverse drug events than the chiropractic group, and I agree with you, it's not a big surprise, but we've quantified it, right? And we've shown that the difference is quite significant, So for the first time, we actually have the numbers. We know the difference in numbers. So to sum up the results of the regression analysis, when we control for patient characteristics and health status and propensity score, which is a way of controlling for selection bias, the adjusted rate of adverse drug event was more than 42 times higher for initial choice of opioids versus initial choice of spinal manipulation. And of course, that's a statistically significant result. Moving on to efficiency, right? This domain of quality where we want to look at the efficiency of care and compare these long-term outcomes for spinal manipulation versus opioids regarding escalation of care, right? Same basic data source and population research design as the safety study. But we looked at escalation of care. So what does that mean? It means encounters indicative of an escalation of care for chronic low back pain might be a hospitalization, emergency department visit, advanced diagnostic imaging like an MRI of the lower back, specialist visits, say to an orthopedist or a neurosurgeon, or really anyone other than primary care that might see someone for low back pain. And even lumbosacral surgery and interventional pain medicine techniques like injections, and also encounters for potential complications of chronic low back pain would also indicate the escalation of care beyond what ought to be happening in most cases of kind of garden variety non-specific low back pain, which is mostly what we found among Medicare beneficiaries. It was mostly non-specific low back pain, meaning back pain without a pathological or an organic cause. So here are the results: proportion of clinical encounters indicative of escalation of care Again, looking at those combined cohorts that either started with opioids or started with manipulation. And you can see again the pretty big difference. Look at the figures in parentheses here. 92.2% of those who started with opioids had a secondary care encounter indicative of an escalation of care, as compared to 58.4% of those who started with manipulation. So almost twice as much, not quite. And similar figures as you kind of sub-analyze for the various types of encounters, all increased rates of secondary care encounters of various kinds for the opioid group. So to sum up the results of the regression here, the adjusted rate of escalated care encounters is about 2.5 times higher, not 42 times higher with the safety study, which is a ridiculously increased amount, but 2.5 times higher is still a very, very, very healthy effect size. 2.5 times higher for initial choice of opioids versus initial choice of manipulation. Again, with the weighted propensity scoring, which is we found to be kind of the preferred approach to propensity scoring in Medicare studies on chiropractic. Again, the propensity scoring is meant to adjust for the possibility of selection bias, meaning you could have selection bias if people who chose chiropractic or spinal manipulation are different in some way from people who choose drugs. And no doubt they are. So we try to adjust for that bias beyond with whatever variables we have available to us. So 2.6 times the rate for the opioid group as compared to the spinal manipulation group for escalation of care. On to the next domain of quality or ways of measuring outcomes, and that's patient-centeredness. So the objectives of this part of the study is to compare patients' perspectives on their long-term use of spinal manipulation as compared to opioids, regarding their beliefs about treatments, their health-related quality of life following treatment, and their satisfaction with treatment, comparative satisfaction. So we studied this by means of a survey. But we drew upon our cohorts of Medicare beneficiaries that we had identified in the claims data, and with being facilitated by Medicare, we were able and allowed under the terms of this grant and the permissions that you need to work with Medicare data, we were allowed to actually contact these Medicare beneficiaries and send them a survey to ask them about their beliefs and opinions about manipulation versus opioids. And we knew something about their history because we'd already identified what cohort these patients were in, and whether they used opioids, whether they used spinal manipulation, and whether they crossed over from one to another. So there was a total of about almost 2,000 surveys that went out to Medicare beneficiaries. We didn't get a particularly good response rate with 195 responses that we were able to use, right? They were complete and valid, but it was enough to achieve statistical significance in comparing the results. So we used a numeric rating scale to measure patient satisfaction. We used the low back pain treatment beliefs questionnaire to measure patients' beliefs about their treatments, and SF-12, kind of standard way to measure health-related quality of life. So to sum up the results of this survey, recipients of manipulation were more likely to be very satisfied with their care, 84%, as compared to recipients of opioids, 50%. The manipulation cohort reported significantly higher health-related quality of life compared to the opioids. And so there were two different components to this: the physical and mental health scores, and the mean differences were 12.85 and 9.92 respectively. And regarding treatment about patient beliefs about treatment, we found that the manipulation cohort had a lower degree of concern regarding chiropractic care for their back pain compared to the opioid cohort's concern about PDT. PDT meaning prescription drug therapy. Okay. So conclusion, basically, to sum that up, the long-term recipients of manipulation had higher self-reported rates of satisfaction and health-related quality of life as compared with the long-term recipients of opioid therapy. Okay, we don't want to forget the denominator in the value equation, so we looked at costs. So the objectives were to study the comparative healthcare expenditures for the two groups. Again, kind of the same data sources and research design and cohort assembly as we use for the safety and the escalation of care studies. So we conducted a comparison of cost outcomes between the cohorts using regression models and controlling for all the various factors that we had on patient characteristics and measures of health status. And also, again, we used propensity scoring to try to even out the cohorts with regard to their propensity to use either manipulation or opioids. So some people would call it kind of a pseudo randomization, which is probably not accurate, but it's as close as you can come sometimes with this observational study to equalizing your cohorts. So also a lot of stuff in this table, but I'm going to help you kind of narrow it down a little bit. And we're looking at this line, Medicare payments for low back pain. So these are payments specifically for care of low back pain, for spine, for visits with a primary diagnosis of low back pain. And you'll see here that if you look at the figures for the means, right, for spinal manipulation, that the costs are higher. The costs are higher for the spinal manipulation group than for the opioid group, okay? Which is, I guess, in some ways not surprising, because to get spinal manipulation and get repeated office visits at a chiropractor's office probably costs more than filling the prescriptions for opioids. However, these figures also include any visit for low back pain. So it includes all of that escalation of care, right, that we saw, which is much higher in this group, but still the costs are lower for the opioid group, okay? But that's not the end of the story. The total costs under Medicare for all health care are much, much higher in the opioid groups, right? So there seems to be a cost offset. So look here, this is more than twice as high for Part A in the opioid group. That's allowed charges. For payments, again, more than twice as high for payments, 28,000 per beneficiary versus 12,000. Part B, 57,000 versus 36,000. And Part D, whether it's the actual Medicare payments or the patient's out-of-pocket costs, again, much higher for the opioid group. So we didn't analyze to determine exactly where the costs are coming from, but there's quite there is a a body of literature that talks about the costs of treating the adverse effects of using opioids, and those are actually quite high. And I'm not going to cite those studies here. I could, but what I have to show you is this map, which I think in very dramatic fashion gives an idea of the costs for treating opioid use disorder as a percentage of state gross domestic product. This was 2 years ago. So the gross domestic product, they say that's everything. That's all the economic activity in the state. In New Mexico, it's more than 5% of GDP. Ohio, Michigan, Kentucky, and Maine is more than 8%. In West Virginia, a state that can ill afford this, more than 16% of GDP goes to the cost of opioid use disorder, right? So the costs are significant, and this may account for the cost offset, right? That if you spend a little bit more on treatment for manipulation versus opioids, the overall costs, overall healthcare costs under Medicare for a patient come out lower. And here's the results of the regression analysis on costs. And the bottom line is that we had about 21,000 patients who started with opioids, about 6,000 who started with manipulation. And with all the controlling that we did, the opioid cohort incurred overall health expenditures 1.87 times higher than patients who started with manipulation. And again, these are all statistically significant results, as they always are in Medicare, because the N for all your studies is so huge that you can get statistically significant results for anything. Okay, so to sum up the value, right, of manipulation versus opioids, right? The value is outcomes over costs, right? So for safety, because we have decreased adverse drug events, right? And for everything, lower costs, right? Higher value with regard to safety. Higher value with regard to efficiency because there's reduced escalation of care and lower costs. And higher value for patient-centeredness with increased satisfaction with care and lower costs. Okay, so that's all part one. So part two, right? The association between use of chiropractic and use of prescription opioids. And I'm going to show you the results of a couple of our studies. But first, just a little bit of review of the literature on this. There have been a number of studies quite recently. We're not the only ones looking at this, but it's interesting because everybody's pretty much finding the same thing. So here's the systematic review, came out of Yale a couple of years ago, showing that chiropractic users had a 64% lower odds of receiving an opioid prescription as compared to non-users. And here's the forest plot from that systematic review. Now, you can see that all the studies showed lower odds for recipients as compared to non-recipients. So the blue line is 1, that's equivalence, right? So the odds of 1 means it's the same for the chiropractic users versus the non-users, right? But here's the mean of all of these studies. Here's our study that we did a couple of years ago. You see it lines up really closely with 3 other studies. Pretty amazing that the results all come out just about the same. Then there were 2 other studies that showed even lower odds, right, for getting an opioid, particularly this one, much lower odds. But the mean result, again, was 64% lower odds of receiving an opioid prescription if you use chiropractic as compared to if you don't. Since that systematic review came out, this very large-scale study with 216,000 individuals came out and was published in BMJ Open. And found, again, initial visits to chiropractors or physical therapists is associated with substantially decreased early and long-term use of opioids. And then here, this is our study. It was published earlier this year. Again, found really, really similar results. Patients with spinal pain who saw a chiropractor had half the risk of filling an opioid prescription compared to those who didn't see the chiropractor. And then also, interestingly, among those who saw a chiropractor within 30 days of diagnosis, the reduction in risk was greater, right? So this is part of the literature that justifies this approach that we took, or it's actually more confirming the literature that if you start with a chiropractic or you see the chiropractor early, your outcomes are better. And so that's why we use those cohorts where where had people either initiated with opioids or initiated with chiropractic. So one more study that shows that effect. And now this study, this is the one actually I presented at the AIHM conference last month. The study has not been published yet. We're hoping to submit this very soon. But again, look at this, 56% is the same. The statistic over and over again is so close. Adjusted risk of filling an opioid prescription within 365 days of initial visit was 56% lower among recipients of chiropractic care. And this is Medicare, right? This is Medicare. This is nationally represented Medicare data. Again, we studied claims data. This was not part of the NIH study. This was a privately funded study. But again, very, very similar results. So, and this is the a Kaplan Meier graph showing the results of that study in a different way. This is like a survival analysis, which is usually used to indicate a survival of, say, patients with cancer. And so, but we use it in a different way. Here, it's not survival, it's the probability of not filling an opioid prescription, right? The red dashed line is the recipients of chiropractic, and the blue line is the non-recipients. And so you can see that throughout the study period, the probability of not filling a prescription was high, consistently higher for the chiropractic users. Just a different way of looking at the data. But demonstrating that kind of the causal kind of before after effect, right? So kind of moving on to the last part of what I wanted to talk about, which is health policy. And again, just reviewing these results, right, with regard to the value of spinal manipulation versus opioids, right? In the numerator, we have lower risk of adverse events, less escalation of care, higher patient satisfaction, and lower total healthcare costs. So that's the value, right? High numerator, low denominator, high value. Now, why does this relate to chiropractic? Because we were studying spinal manipulation, right? In the most part, at least in part one, that was all about spinal manipulation. Part two was about chiropractic, where we talked about the association between using opioids across between users and non-users of chiropractic. But for spinal manipulation under Medicare is pretty much chiropractic. 90% of all clinicians who provide spinal manipulation under Medicare are chiropractors, right? And so I think that we can infer from these results that more widespread utilization of chiropractic care by Medicare patients could lead to reduced use of prescription opioids and therefore safer, more efficient, more patient-centered, and less costly spine care for older adults. And keep in mind that older adults are a difficult population to manage, right? These are patients with multiple comorbidities, polypharmacy, the care is always more costly and more more difficult in many ways. But and chiropractic care may offer not only an alternative to the opioids, but possibly an upstream strategy for curtailing and the use and misuse of opioid medications and avoiding and realizing that cost offset that we illustrated earlier. So, but here's the problem. Medicare currently restricts reimbursement of chiropractic services to spinal manipulation and does not cover other therapies. It doesn't cover exams, it doesn't cover imaging, it doesn't cover anything else that chiropractors might need to do to provide high quality care to their patients. And so this restrictive coverage of chiropractic may tend to kind of push patients away from this high value approach towards using drugs. So we're recommending that the Centers for Medicare and Medicaid Services expand coverage for chiropractic services. Well, guess what? There is a bill currently before Congress that would do just that. And the bottom line is that under this bill, if it were to pass US Congress, it would provide Medicare coverage for all services furnished by doctors of chiropractic within the scope of their license. Like chiropractic licenses and licensing and scope of practice is determined by the state. So that's why that provision is in there, because it varies by state. But typically in most, if not all states, the scope of practice is greater than that which is currently allowed under Medicare. So this would simply allow chiropractors to do what they do, right? Do what they do best and provide, appropriate care to their patients. Not that they don't already provide appropriate care, but allow them to be reimbursed for that care. And so that would translate to better access. When reimbursement is better, patient access is better, and that's the point. And patients have better access to high value care as opposed to low value care. The patients win and society wins too. And we don't have all those incredible costs for treating opioid use disorder that was illustrated by the map I showed you earlier. So that's pretty much it, but I just want to add that so much of the research that we do here has this kind of health policy objective. We examine what's happening under Medicare. We can kind of compare approaches, compare value, and infer what's the preferable approach with regard to outcomes and costs, and so on, and hopefully that information, that data, will inform appropriate health policy decisions. But our work will be to no avail if folks in federal government, unless those folks actually care about whether patients get good health care or not. So we have election coming up in a few days. I want to urge everyone to vote and keep in mind, and it's so important to preserve our democracy. We all need to vote. But just keep in mind, it's too late to vote by mail right now. So either drop a ballot off in an official drop box or show up in person, and stay safe. So that's all I have to say. Thank you so much for your attention. And I think we probably have some time for questions if anyone has any questions or if we want to talk about any of this further. Thank you.
Dr. Whedon, thank you so much for this incredible research. It's really I love how you lay out all the different areas where, and really ending with that policy. I mean, because that's really where the rubber hits the road for all of us, for patients and clinicians. And it's just really valuable to be able to see that progression. So I really appreciate that. We do have a question from one of our attendees, David DeBoos here in San Diego. He asks, with the studies, was there any differences among kinds of chiropractic care studied, or was it just any chiropractic care that was given when you showed your data?
Yeah, so most of the, pretty much all of the original research that I cited here, the recent research that we did was under Medicare, was using Medicare claims data primarily. And we're kind of limited by what's in the claims. If you think about, I don't know if the questioner is a chiropractor or not, but it doesn't matter if you're a clinician, think about what goes into a claims form, right? There's information about the patient, there's information about the provider, there's diagnosis, there's the treatment procedure, there's something about, the charges, and there's not a whole lot else, right? So as far as when you say types of chiropractic care, if you're referring to techniques, there's nothing like that in there. It's simply, and in fact, the other significant limitation, as I pointed out a couple of slides ago, is that the only service provided by chiropractors that is covered by Medicare is spinal manipulation, right? And we don't even know if with spinal manipulation of the lower back or of the cervical spine, right? So although we can infer from the diagnosis, perhaps to some extent. So the answer to your question is no. we weren't able to distinguish. All we know is spinal manipulation happened or didn't happen.
I mean, I think this is a really important area to discuss because currently just the way that research is so restricted, and the model, the way we collect data, all of these issues around siloing both professions and practices really doesn't give you a way to robustly study, the different ways that we could be doing this. And to me, that's what's really hopeful is once we get there, once we get to, a political atmosphere that really welcomes looking at integrative health, because we're not there yet. We've got this incredible work that many of you pioneers in integrative research are doing against a system that doesn't really want it to happen in many ways. And so I just, to think about what this could look like, if you could really look to studying deeply around different techniques and different, I mean, there's just so much that could be done, and that's very hopeful, I think. But it really does come down to us asking and demanding for the system to change so that we can all receive better care.
Yeah, and one way we could access that information would be through electronic health records. It's another way of doing observational research. It gets more information about outcomes and specifics about the patient encounter.
So another question that's coming in from Dr. Sridharan is asking, why did you choose the opioid therapy knowing the adverse effects it has on the people in various ways? Are there any other therapies for the low back, for back pain that is effective? So I think you were choosing, you were comparing it to opioid data, correct? You weren't necessarily choosing that.
So we can find our inquiry to that specific comparison. There are many other therapies that are effective for low back pain, primarily non-pharmacological therapies are now the ones that are recommended as first-line approach to low back pain. So not just spinal manipulation / chiropractic, acupuncture, massage therapy, cognitive behavioral therapy, to name a few, all non-pharmacological therapies. And those are the first line recommended treatments. Unfortunately, we were interested in the Medicare beneficiary population, older adults, for reasons that I mentioned earlier. It's a kind of a tough group, right, to care for sometimes. A group which, by the way, for which I feel a growing affinity and some reason. But anyway, those therapies are not covered under Medicare, right? Acupuncture now, as of last January, is covered for low back pain, you know, on a limited basis. That's new. And we're hoping that to study the effect of that decision by Medicare to open up coverage for acupuncture, and the data is accumulating as we speak, and we may be able to examine you know, and compare acupuncture in the same way we've done here. Massage therapy is not covered under Medicare, and there are many other, you know, very valuable non-pharmacologic and integrative therapies that are not covered under Medicare. And
so Jim, I do
change.
Yeah, I will. And I will ask this because, you know, those recommendations that came out now at least a year or two ago, right, around the first line of approach being non-pharmacological, while they are now, you know, that is the recommendation, the reality in health systems and for patients is that that's still not happening. And, you know, I can say this from my own personal experience where like what you get recommended might not be opioids, but certainly is not all of these other possibilities. And so, you know, how do we as healthcare recipients even start to bring these types of changes and recommendations to the attention of the systems that we, you know, receive our care from?
Yeah,
Because
you're right. It's not
right?
happening. If you look at the size of the cohorts, I don't remember the numbers exactly, but the opioid cohort was 4 or 5 times the size of the manipulation cohort.
Right.
Right. So that gives you an indication, despite the fact, right, that the current clinical evidence-based clinical guidelines call for non-pharmacologic therapies as the first approach, but it's not happening. And what I meant to, I could have included so much more in this presentation, but can only do so much. We did a number needed to treat analysis, and you know, and it's interesting. It'll be in the paper that we publish that it doesn't take too many patients to switch from opioids to spinal manipulation to prevent an adverse event, an adverse drug event, right? So there's because so many are, you know, are still going with the medication approach first. So there's lots of room for improvement. Yes.
And that policy, you know, we have another question coming in. It's interesting that Medicare does not cover other therapies if they're being found to be effective. Is there any reason why Medicare came up with this policy? I mean, we do know from other evidence-based research in many different areas, whether it's nutrition or in other integrative areas, that sometimes from knowing, having the evidence to actually having the policy changes be implemented is 10 years or more, right? We're looking at decades, and like, how is that serving the patients, right? We know this data, we have so much data now. So any insight around that, just the policy?
There's such a lag between evidence and practice, right? Chiropractic has been covered under Medicare since the early 1970s. The decision to allow coverage of chiropractic under Medicare, but it's very limited, and it's been limited for 40, how many years? 45 years, whatever. But the decision to cover chiropractic at that time was not a scientific decision. It was a political decision. There was no research at that time to speak of on chiropractic or spinal manipulation in the early 70s. Now we have an abundance of research. I believe we're moving into a new era, right? Acupuncture got some coverage just this year.
Yep.
But chiropractic still not full coverage. We're still lobbying for that. But I think I think we're going to see an acceleration in adoption of evidence-based integrative care, right, and coverage under Medicare. You see it in the private health insurers covering these things to some extent. I guess the federal wheels turn a little more slowly sometimes.
Well, and certainly, we know just from the really amazing work being done at the VA through the whole health initiative, that system, which is the largest health system in the United States, is also changing, and that's very hopeful, because I think we'll be able to use those types of the results from that program and the work that's being done there to also move forward bills like this, like HR 3654, which will ultimately result in every one of us as patients in the system having better care. And that's the goal, right? The goal is that we live healthier lives and have access to that pathway, the quickest pathway to get there, in the United States and beyond, honestly.
That's right. And I just switched back to this last slide to point out that in the bill, it says here in number 4, this act would bring Medicare coverage, chiropractic coverage, more in line with that provided by the Department of Veterans Affairs, Department of Defense, Federal Employee Health Benefits Program, and private health insurance coverage. So Medicare is kind of bringing up the rear in this area. But it can lead. Medicare in many cases has led. If Medicare says yes, then everyone else tends to fall in line.
As individuals, is there anything you would say that we can do to help move these types of initiatives along? I mean, beyond voting, we all know it's important to vote. Please get out and vote this year. It's so important. But are there other ways that we can use our voices, either individually or collectively, to really help make these changes a quicker reality?
Yeah, I don't know. I'm just a simple researcher and I'm not a health policy guy. I hope that my work informs health policy decision makers. But maybe work with your professional associations and work with AIHM. Right? I mean, we're all in this together. It's not just the chiropractors or just the naturopaths or just the acupuncturists. We have a common interest. And so let's work together.
Great. Well, thank you, Jim. We're just really so blessed to have you in our community. And this type of research is truly critical to patient-centered care everywhere. And I just really thank you for all that you're doing and your team is doing. We are very much aligned with all of the work that y'all do at SCU, Southern California University of Health Sciences. And this year, Dr. Whedon actually was the winner of the research, the AIHM Research competition at our annual conference, along with some of his students. So please go to our site, aihm.org/research, and you can see all of the incredible research that, there was over 20 submissions from around the country and around the world, actually, around integrative health research. And use that, bring that to your doctors, inform them, educate them, and we'll keep moving all of this forward. So if I could share my screen for a minute. Okay, so just to finish up here, let's see if just next week, we will be having a weekly meditation. I'll actually be leading that on Monday morning at 8:30 a.m. Pacific time. And then our next Friday wellness webinar will be with Dr. Paul Epstein, who's a naturopathic doctor. And we're just really thrilled to have him. Please stay in touch with us. You can sign up for our emails on our website. All of our wellness webinars and Monday meditations are free. Whether you're in our community or you're just in the general public, we welcome you and would love for you to participate. You can also, if you're interested in learning more and getting more education, we invite you to learn about our fellowship program for licensed clinicians, medical doctors, nurses. It's a really great way to get more education around integrative health. And we have 2 days left for, our online conference. This year was such an amazing success. It was our first virtual conference that we've ever had. The access is still available until November 1st. So if you attended, go in and keep watching the videos or rewatch, download any of the content that you wish to. If you haven't yet, you still have a couple of days to do that. And this was actually our Research Awards ceremony, where Dr. Whedon actually won this year's top prize. So please, you can go in and see the event. It was really wonderful to see just all of the amazing researchers from around the country and globally who are doing this work. So to connect with us, if you go to our YouTube channel, youtube.com/AIHM Global, all of our webinars you can access afterwards if you want to go back or share this webinar with anyone and your colleagues, your patients, your friends, your family, your doctors. Please do so. You can also connect with us at that hashtag AIHM Global on Twitter, on Facebook, on LinkedIn, and on Instagram. So please consider joining the integrative health community, become a member of AIHM, or join a local student chapter or student alliance. So thank you all for attending today. And Dr. Whedon, again, thank you for all you do and your continued success.
Thank you very much. Thanks everyone for listening. Appreciate your joining the webinar.
Bye-bye now. Have a wonderful weekend and vote. Go and vote.
Yeah.